Section of this lecture, Learning Plan 5, Part H, is all about cardiac dysrhythmias. I will probably try to draw some of these on the board in class. Please don't laugh. I am not an artist, but sometimes it's easier to draw things out than to just talk about them, but I'm going to just talk about them for now. Just so you understand, by the way, in case I forgot to mention it, this lecture was one of my favorites because I like the heart stuff, right? I used to be a cardiac nurse, a critical care nurse. When I was a certified nursing assistant, I was also trained to be a monitor technician and obtain EKGs. I know how to read this stuff. I know how to work with it. So you can ask a lot of questions and I'll be able to answer, well, not all of them because I certainly don't know everything, but I can answer quite a few of them. I like this stuff. So I'm a bit of a geek about this and I'm not afraid to admit it. Cardiac dysrhythmias. Remember now, dysrhythmia, D-Y-S, always means bad. And of course, this means bad rhythms. As opposed to arrhythmia, which is no rhythm. And an arrhythmia may be bad. It's not desirable, but not necessarily immediately dangerous, although it could be. A dysrhythmia is a disturbance of the normal electrical conduction resulting in the abnormal heart muscle contraction or rate. So, when you have a dysrhythmia, it's either going to affect the speed of how fast it contracts, either too fast or too slow, or irregularly, or it's going to decrease the function of the contraction. Maybe part of the heart will contract stronger than the other part, and it'll become off balance. There are anti-dysrhythmics and anti-arrhythmics. These are drugs that treat and prevent disturbances of the cardiac rhythm. Dysrhythmias are caused by many things. Hypoxia, common. So a diminished amount of oxygen in the blood, hypoxia. Electrolyte imbalances. What's the most common electrolyte to cause dysrhythmias? Potassium. Potassium. Remember, potassium is also what's used to kill people for lethal injections. Think about that when you're administering IV potassium. Ischemic heart disease. We talked about that earlier with angina and myocardial infarction. When you're having muscle cell death in the heart, that will almost always trigger some sort of dysrhythmia. Febrile illness. Believe it or not, a very high fever can damage the heart. Exercise. Yes, exercise can cause dysrhythmias. I am not saying you should not exercise. I am saying, though, that if you exercise and something feels wrong and it is consistent, you need to get it checked out. It is possible that you have exercise-induced dysrhythmias which need to be looked at. Emotional upset. Yes, emotions will trigger our heart to beat irregularly. Caffeine, decaf. I drink decaf, but that's not because of dysrhythmias. It's just because I'm trying to get away from caffeine. But if you drink a lot of caffeine, and how many of you students drink a lot of caffeine? If you don't now, you will. Nursing school is where I learned to drink a lot of caffeine. I never drank it before nursing school. By the time I got done, I was drinking way too much. Cigarette smoking, the nicotine is a stimulant and it can cause dysrhythmias. Drug therapies like tricyclic antidepressants, digoxin. We talked about digoxin that causes the heartbeat to beat slower and stronger. And then CNS stimulants. People that have ADHD maybe use Adderall or Ritalin. That can cause dysrhythmias. As well as illegal drugs such as cocaine, methamphetamine, and please don't use those. That's going to get you in trouble. And hyperthyroidism, not hypothyroidism. Hyperthyroidism will definitely cause cardiac dysrhythmias. So we have the SA and the AV node, and you'll see a good picture of a cutaway view of the heart here. But we're going to need to talk about this a little bit more to really understand everything here. So we're going to give drug therapy because cardiac dysrhythmias require accurate identification of the dysrhythmia to understand the basic mechanism which is causing it. EKGs affect the dysrhythmia and expectation of the therapeutic effects. In other words, we need to know what's causing it before we can treat it. Does that make sense? You know, think about it. If you have an infection, you have a fever, you can take ibuprofen, Tylenol for the fever. But unless you know what's causing it, are you really going to do anything? So if you have an irregular heartbeat, until you know why you have an irregular heartbeat, it's hard to safely treat it and effectively treat it. So the SA node, it's considered the pacemaker of the heart. It controls how fast the heart beats. It's found in the upper part of the right atria. It's called the heart's pacemaker, the natural pacemaker. And the normal rate of the heart is 60 to 120 beats per minute for an adult. For children, it's faster. But for adults from about age 12 or so on, 60 to 100 is normal. That's a large range. And a lot of things can affect it. The general physical fitness. A person who's physically fit usually will have a slower heart rate because their heart doesn't need to beat as fast. If you're very overweight, like I used to be, your heart had to beat, my heart was beating a lot faster on a regular basis because it just needed to beat harder to push that blood through all that fat tissue. A person who is very physically fit, long distance runners, swimmers, and bicyclers are the most common. Their heart will beat, when they're at rest, abnormally slow. Lance Armstrong and Michael Phelps, the swimmer, Armstrong the biker sounds like he's in Hell's Angels. The bicyclist, their resting heart rate is in the low 40s. Most of us, if we had a heart rate in the low 40s, we'd be very dizzy. But their heart is normal that. When they're exerting themselves, their heart rate goes up to 70. And a lot of ours, we have resting heart rates at 70. So 60 to 100 is normal. But some people's normal could be as low as mid-40s. Some people have a normal 110. So take 60 to 100 with a grain of salt. We have to look at the person's normal before we take action. Heart rate is controlled primarily by the autonomic nervous system. Autonomic stimulation produces positive inotropic function or contraction, and also positive chronotropic function, rate, and positive dromotropic effects, or the rate of electrical conduction. So that's what the autonomic stimulation does. Parasympathetic nerve endings that are located near the SA node and in other parts of the atria and ventricle also. Now with stimulation of these nerves, or vagal stimulation, acetylcholine is released at the junction of these nerve cells. And what is the parasympathetic response? Decreased inotrope, chronotrope, and dromotropic effects. This happens a lot in elderly who are constipated. Let's think about that for a moment. If you stimulate the vagus nerve, that releases acetylcholine, and that acetylcholine reduces, has the effect, that's a cholinergic, which has an anti-adrenergic or adrenergic blocker effect. So everything slows down. Okay? So when a person is constipated, they need to strain to have a bowel movement, right? When you strain, when you you are purposely stimulating the vagus nerve, because the vagus nerve controls all the guts. So when you're purposely stimulating the guts to have a bowel movement, you are causing your heart rate to slow down and to beat less strongly and have decreased conduction. It's very common for people to slow their heart down a lot. It's possible for you to slow down your heart enough for it to stop. Now, it doesn't happen all the time, but you can drop your heart rate by straining too hard. So that's why the elderly are almost always on chronic stool softeners and laxatives. We want to eliminate the need to strain or to stimulate that vagus nerve. Because if their heart is if you think about it, if you're in your 70s, 80s, 90s, your heart is probably already not at its best function. So if they strain and get that vasovagal response, that's the technical term, they get a vasovagal response strong enough, they could have a heart attack and die. They could just have a cardiac arrest. So that's why we pay attention to the bowel functions in everybody, because it has such a profound effect all over. Sorry, I got an itchy nose right now. Dysrhythmias are classified by the location or type. Could be a flutter, a fibrillation, or a block. And they have different outcomes, different ways of treatments, and sometimes some of these are not even going to be treated at all. It depends on the severity, like everything in life. Changes in sodium and potassium levels generate the action potential in the myocardial cells. So depolarization occurs when sodium and calcium rushes in, and repolarization occurs when potassium is pulled out. So that's how heart muscles contract. So if you can imagine, if you have less potassium, it's going to change that function and make your heart more prone to irregular heart rhythms. The von Willebrand classification, this is how we classify antidysrhythmic drugs. And there's class 1, 2, 3, and 4. These are based on the effect produced by the particular drugs. So 4 classes. 1 blocks the sodium channels. 2 decreases spontaneous depolarization. 3 prolongs the action potential, and 4 blocks slow calcium channels. Okay? So antidysrhythmics, those are the four types. And just like with anticoagulants and antithrombotics and blood clotting agents, the anti-clotting agents all work on a different part of the chain, the clotting cascade. These work on a different part of the dysrhythmia function. So you can use multiple drugs to get the same end result, but again, using smaller amounts of each drug for a reduced chance of side effects. And I keep repeating that because that's really important. The more different types of drugs, different drugs that are used for the same purpose, the less of each individual drug is needed. So class 1A, or sodium channel blockers. These are the oldest classification of dysrhythmics. Quinidine gluconate, or quinaglute. This is the prototype, the first sodium channel blocker. It's used for atrial tachycardia, flutter, and fibrillation. This decreases the myocardial excitability of the cardiac muscles, decreases the velocity of electrical conduction. It has a negative chronotropic effect. It also has a cholinergic effect, so it's a vagal blocker. So what do you suppose this could have as an end result? Side effects? Well, GI problems, nausea, vomiting, anorexia, diarrhea, severe hypotension, and tachycardia. Tinnitus, headache, dizziness, impaired vision, vertigo, respiratory problems. You can have respiratory arrest, and hematological problems such as hemolytic anemia and agranulocytosis. Class 1 agents do not prolong survival in any group of clients, and their use is now declining. It's declining in clinical use mainly because the pro-dysthymic effects and results in increased mortality rates. So they were the first drugs to be found, but they're not that good. They have a function, but since other drugs are so much better with so fewer side effects, you will almost never see these in use. They're the largest group of antidysrhythmics, and they act by slowing the rate of impulse conduction across the heart, but they don't have any increased survival. You need to use them carefully with heart failure patients, and the side effects are so severe that the quinidine is discontinued in 1/3 of patients who take it. Other agents like procainamide or disopyramide are ordered instead. Anticholinergic effects, you need to be cautious with people who have urinary retention, glaucoma, or myasthenia gravis. These can increase digoxin blood levels. And remember, this digoxin has a very narrow therapeutic effect. You need to give it with meal, and you will always use a test dose to make sure that the person can tolerate it. I've never given it. That doesn't mean it's not used, just that I've never given it, and I worked in a cardiac unit. Class 1B sodium channel blockers, these are lidocaine, most commonly known as, lidocaine is the generic. These sodium channel blockers are the largest group of antidysrhythmics. These are used for ventricular dysrhythmias and as a local anesthetic. So they can be injected subcutaneously as an anesthetic if you're going to get sutures or minor surgeries. It decreases myocardial excitability in the ventricles. Increases the ventricular fibrillation threshold, meaning it makes it harder for your heart to go into ventricular fibrillation, or VFib, and VFib is a fatal rhythm. It eliminates or reduces ectopic foci stimulation in the ventricles. So it's commonly used when a person is having VTAC to slow their heart, reduce the likelihood of VFib, and reduce the frequency of premature ventricular contractions, or PVCs. It can have CNS toxicity, so you can develop seizures and confusion. You can cause respiratory depression or arrest. It does have cardiac effects like hypotension, bradycardia, and it can actually cause dysrhythmias. It can cause cardiac arrest. If you are allergic to local anesthetics, you cannot use lidocaine. That said, it is used frequently in code situations. It works really well, usually. Class 2 antidysrhythmics are beta blockers. Most common is Inderal, that's the brand name. Generic is propranolol. And remember, this is also used for things like performance anxiety, right? So propranolol treats ventricular rate in atrial fibrillation and flutter. Now this does not stop the atrial flutter or atrial fibrillation, but it reduces the ventricular response to it. Some people with AFib develop, we say AFib with RVR. AFib, atrial fibrillation with rapid ventricular response. And that's not well tolerated by a lot of people. And that can lead to other dysrhythmias. So propranolol is used to stop that rapid ventricular response. It doesn't treat the atrial fibrillation though. It's a negative inotrope, chronotrope, and dromotrope, and it decreases the conduction velocity through the AV node. Side effects: dizziness and lightheadedness from the CNS system. Bronchoconstriction again. Remember, these are not used for people who have asthma. It can cause hypotension and bradycardia, and it can cause heart failure. Weakness, fatigue, and impotence are major side effects. And impotence is one of the most common reasons people will stop using it. That's a major lifestyle effect. And seriously, if it's going to make you impotent and just totally disrupt your life, we need to find a different drug, right? Which is why there are different drugs. So we have class 3, which are potassium channel blockers. This is the classic one is amiodarone. That's the generic. The brand name is called cortisone. We'll call it amiodarone. And this is used for supraventricular and ventricular dysrhythmias. So supraventricular is above the ventricles or in the aorta area, and ventricular. So this will help a person who's in AFib, or a person who's having supraventricular tachycardias, or paroxysmal atrial tachycardias. It treats a lot of things. Oh, I'm having really a lot of itching. Sorry about that. It prolongs the action potential of atrial and ventricular tissue. It delays repolarization and causes systemic and coronary vasodilation. So slows the electrical impulses and causes vasodilation. So what are some of the side effects? This is odd. In the eyes, it causes yellow-brown granular deposits in the corneas. It can cause pulmonary toxicity in the lungs. Bradycardia and hypotension. So you need to always check pulse and blood pressure. A lot of GI symptoms: nausea, vomiting, constipation, abdominal pain, anorexia. And remember, when we say anorexia in terms of pharmacology, we're not talking about anorexia in terms of the mental illness or mental condition or eating disorders or whatever you want to call it, like anorexia nervosa. Here we're using anorexia in the purest term. Anorexia means no appetite. Okay? It can cause integumentary problems, a bluish discoloration of the skin. I've never seen that, but it happens. Photosensitivity, you're very sensitive to light. Hepatic dysfunction, muscle weakness, hypothyroidism, low thyroid function, dizziness, fatigue, and malaise, or just no energy. A lot of side effects. These potassium channel blockers, they prolong the refractory period of the heart. They slow repolarization, slow the movement of the potassium, and prolong the refractory period in both the atria and the ventricles. As with beta blockers, they're associated with less ventricular fibrillation and decreased mortality compared to the class 1 drugs. So they have much better outcomes than class 1s. These need a loading dose. Sometimes it requires 2 weeks or more before it gets function. That's when we're using it orally. It's also given IV with very fast onset. But when it's given orally, up to 2 weeks before you get any sort of a good feel for what's going to happen. Very long half-life. Effects may last several weeks after you stop the drug. Absorption and elimination is variable. Maintenance dose is very difficult to determine. So we use a loading dose to reach that therapeutic level. But figuring out what the maintenance dose is going to be takes a lot of titrating. And titrating, remember, is increasing or decreasing a dose until you find that one dose that works for your patient. So what will you be assessing in your patients until you find that stable dose? Blood pressure, pulse. You'll be looking for side effects. You'll be assessing for CNS problems. So all those, it's a complex medication. Side effects are very common. 15 to 20% of the people discontinue their therapy because of adverse reactions. 1 in 5 will stop taking this because they can't tolerate it. But most are dose dependent, and most of these side effects will decrease and disappear with lower doses. However, if the lower doses result in a resumption of the dysrhythmias, this drug will not work. GI side effects are about 25% of the people. Pulmonary toxicity, non-productive cough, dyspnea, and chest pain with deep inhalation. You need oxygen therapy and sometimes intubation and ventilators. So if a person on amiodarone develops that non-productive cough for no apparent reason, and they say it just hurts to breathe, we need to notify the physician immediately. And be aware that these effects may last for weeks before they go away. Now we're going to go to antidysrhythmics class 4, or calcium channel blockers. We've talked about these before. We're going to finish off here right now. Verapamil is the most common calcium channel blocker used here. Verapamil is the generic. The brand name is Calan, C-A-L-A-N, or just say Verapamil. That's how doctors almost always will prescribe in generic terms. This is used for paroxysmal supraventricular tachycardia, or PSVT. It's used for rate control in atrial fibrillation and flutter. And I will draw a picture of the difference between AFib and aflutter. It looks very different on a cardiac monitor. It has a very similar side effect, though, a similar effect on the body. This inhibits the movements of calcium across the cell membrane. It causes the relaxation of vascular smooth muscles and vasodilation. That's why we use it for hypertension, remember. Relaxes the smooth muscle, vasodilates. It slows electrical impulse through that AV node. Side effects: CNS toxicity, dizziness, fatigue, and headache are very common. It can cause respiratory depression or respiratory arrest. Cardiac effects, most commonly hypotension and peripheral edema. Remember, that's the vasodilation and the relaxed smooth muscle cause swelling and can pool blood, especially in the dependent tissues of your legs when you're standing or sitting. Cause heart failure, constipation, diarrhea, and nausea. Have you noticed a lot of drugs affect the guts? It's very common. So you will always be assessing the person. How does their stomach feel? How are their bowel movements? Are they having bowel movements? The action is very similar to beta blockers. Different action with the same end result. That's why you can use them together, smaller doses. That's why you use calcium channel blockers if you're an asthmatic, because this won't have the same effects as a beta blocker does. Calcium channel blockers may increase the levels of digoxin. And remember, digoxin is used to slow and strengthen the heart. Grapefruit juice will increase verapamil levels. So if a person loves grapefruit juice, you're going to have to tell them that they can't have it, because it increases the levels and you're at a much greater risk of the side effects. And the side effects can be profound. There we go. We've covered the 4 classes of antidysrhythmics and cardiac dysrhythmias. I hope you understood a lot of this, but I expect that we'll be discussing this in class more. And again, we will be going over a lot of the hands-on skills in class, so make sure you understand these. Bring your questions. Bring a lot of questions. I really like questions. Thank you for listening and watching, and I'll see you in class on Monday.